Social pressure often makes the woman feel that okay, I am doing my job, I have to take care of this family, and they are ignoring the symptoms like initial symptoms like painless lump. Prostate cancer, men often hesitate to discuss symptoms like urinary problems, and also it's around this masculinity and weakness. Analogy of cooking. If I can consider the staging, it is 1, 2, 3, and 4.
Welcome to today's podcast on MedSynapse, where we bring you insightful conversation with leading experts in the medical field. Hi, I'm your host, Dr. Smarika Bhatt, and today we are honored to have renowned medical expert Dr. Sudip Haldar, a passionate surgical oncologist. He is dedicated to advancing cancer care through clinical expertise, education, and innovative research. He is also specialized in breast cancer, gastrointestinal oncology, head and neck cancers, and more. He has prioritized patient centric outcomes and cutting edge treatments. Currently, he is the head of surgical oncology at Hope and Heal Cancer Hospital. He has led multidisciplinary team in managing complex cases, contributing to tumor board discussions, mentor peers, and ensure healthcare quality as a certified NABH assessor. It's great to have you on the podcast, Dr. Sudhi.
Hello.
Hello.
Thank you for
Cancer.
the kind introduction.
Cancer is a topic that often brings about fear and hesitancy. So let's dive right into the addressing some pressing concern. So Dr. Sudeep, let's start with the fundamental question. What are the main hesitancy concern about cancer among the general population, and how can healthcare professionals address these effectively?
Okay, so it is a very important question because many of the times when we find patients possibly from somewhat remote places, we got a lot of hesitancy. So this hesitancy is basically multifactorial. And in my experience, if we can dig down and deep, there will be some social stigma. So patients often fear about being labeled or isolated for their diagnosis. Next important thing is the financial burden. Many associate cancer with cost and not realizing that early treatment may be less costly or less expensive. So that is another thing. And next is fear of death or pain. Cancer is equal to pain and no answer about that. And we have to be bear that pain. So that is keeping in mind. And that is haunted most of the patients. And another thing is denial and misinformation, seeking multiple opinions. And the most important and most bad thing is that when they seek for non-scientific treatment procedures. So that delays the start of the proper treatment. And
Okay.
as a healthcare professional, what we can do, we can actively listen. What talking about, these are the category of hesitancy. It's more than that. But if we can categorize this social stigma, financial burden, and fear of death, and this denial is the most important thing. What I felt, and what we can do as a healthcare professional or expert, that in a busy OPD, though it is possible, we have to listen. We have to listen the fear. We have to listen about the hesitancies. That is the one thing, so that they can be more free to express their problems. Next is I have to ensure, or most of the oncology center have to ensure about the treatment according to the guidelines, so that there will be no confusion regarding the treatment. Why I am treating like this fashion? Why I am giving chemotherapy before surgery, or why I am doing upfront surgery? This should be clear to the patient's mind. And empowering patient is one of the thing. Majority of the patients where I felt the caregiver, in view of problems and the fear, they don't inform the patient regarding their diagnosis. But I think they should also know, the patient should know about their diagnosis, obviously in a gentle form, in a slowly, in a gradual way, so that they can feel the emotion, they can feel the problems, and they can by their own have become strong to fight this difficult fight. So this encouraging observation, one thing is that the young patients, the breast patients that with some problem with the breast that may not be malignancy, but they come to us in a frequent way, and this is encouraging. And that is the way when I can teach them the self-weight examination and the other things, that painless lump is the most important thing rather than a painful or breast cyst or fibroadenoma. So I think these are the ways we can tackle the hesitancies.
Okay. So let's move on to another challenge called stigma. Some cancers like breast, cervical, and prostate cancer often carry a stigma. And how can healthcare professional combat with this with their patient and educate them?
If we consider the breast cancer, then many women associate breast cancer with a loss of femininity, self-esteem, and desirability. Social pressure often makes the woman feel that okay, I am doing my job, I have to take care of this family, and they are ignoring the symptoms, like initial symptoms like painless lump. And fear of mastectomy is another thing. Whenever some patients come to me, they feel I don't want to get rid of my breast. So that is another stigma. And for the cervical cancer, it is HPV related. Somehow it is genitourinary malignancy. So it may be sexually transmitted. So they often carry the stigma of promiscuity and pursue some moral judgment. We can judge the patients and also in their family. Regarding the prostate cancer, men often hesitate to discuss symptoms like urinary problems, and also it's around this masculinity and weakness. So these are the stigma, I think, in this sort of malignancy, rather than in the GI malignancy or other malignancy that is less sort of problem. And in oral and head and neck cancer, whenever the patient came to us and we told that we need to do surgery, there is a massive surgery with reconstruction. Then there is some issue regarding the facial asymmetry, all these problems. So these are the stigma, and anything, the first thing we have to acknowledge, then we have to address the problem. Like breast cancer does not equivalence to mastectomy. Most of the time, we can have a good results cosmetically as well as the oncologically by breast conservation surgery. Cervical cancer, we should not judge the patient accordingly. Patients are basically feeling that they are being judged, but we have to ensure them
Absolutely.
that HPV is a viral infection, so it may occur to anybody. It is not related to any sexually transmitted disease. So these are then prostate cancer for male patient. We have to emphasize the treatment for stent, and it should not be encountered as a weakness. So to educate the patient, we need to show the success stories of the other patients, their care survivors, and also highlight role models from similar social or cultural backgrounds. So these are the things, and I don't think every cancer have a screening program, but these breast cancers and cervical cancer, we have some important screening test, and we have to be very much propaganda this screening test in this sort of cancer, so that the majority of the patients can be detected in the earliest stage.
That's a very powerful insight. So let's shift to cancer prevention. How can clinicians raise awareness about genetic counseling or cancer risk factors to the patient?
It is a very pertinent question because most of the patient feels that this cancer runs in their family, and is it genetic, is it familial? So genetic counseling and understanding the familial cancer, the risk have become clinic crucial because there are two ways. One, we have to identify those families who are actually in the high risk, and also in the era of precision oncology and this molecular biology that determines the upcoming treatment, so that we have the actionable direct mutation gene like that. So, and then have to find out the actual mutation and the actionable mutation that is in the form of syndromic management like BRCA positive, BRCA1, BRCA2. And non-familial cancers are majority. There are more than 90% of the patients which we find either they don't have a actionable mutation, or we don't have the connecting links to find this is due to this genetic defect. So again, the lifestyle changes, the other things that is important, and I've already told, like in breast cancer, we are now seeing the HER2 positive, so we can give trastuzumab. So these are actually very important drugs. So this molecular signature is very important. And at the same time, like BRCA positive, we have some drugs like olaparib. So this, from treatment perspective, it is important to identify those groups, and also to identify the groups, the families, the subsequent generation may be tested for the screening, so that we can prevent, or we can prevent this cancer from happening.
Absolutely agree with you that root cause identification is an important aspect in this identification of the cancer. Now let's talk
And
about.
another thing I just to tell that I often want to emphasize that we have to be in the balance. We must ensure that syndromic and familial cancers are not missed, and at the same time, we should not overemphasize the genetics to point of creating undue fear in the patients with the familial disease. So we have to very much mitigate this problem by having some good family history, uh, pedigrees, so that we can identify these groups, families are at risk, these families are not that at risk, so the moderate risk, or they are in the low risk. So accordingly, we can manage accordingly. We can screen those patients.
Okay, absolutely agree with you regarding the history taking is important to actually diagnose the patient. Now let's talk about early detection. So, Dr. Sudeep, early detection saves lives, as we all know. But how can
Yes.
clinicians improve patient education on the importance of screening programs? Because people fear to have screening programs and they don't want to do it.
Early detection is a game changer, and for that we need to simplify the message. So that it is like other tests, like we are test for the complete blood count in a 6 months or in a 1 year for our lifestyles. So this is actually happening. So at the same time, that are preventable like cervical cancer that I already told about the breast cancer. Self-breast examination, mammogram after 40 years. So these are the things which should be encouraged. And we were the community health workers. Actually, we are seeing the tip of the icebergs. Majority of the patient for this hesitancy, fear, all these things, they didn't come. So if we can leverage the community health worker, train them how to detect the patients that should be referred, that should be treated early. So that is a very important thing. Another thing is share stories. The patients who already survived, already fight with the cancer, and then is doing his normal life. It is very important. And involvement of the some famous personality or some stakeholders, that is important to bring some changes. So I think that will be the important steps to improve or increase the screening.
So, as you have emphasized on importance of mammogram, so once
Mm.
diagnosed, and it explains cancer stages and treatment is crucial. So, in what
Mm.
innovative way can physicians explain the stages of cancer and treatment option to the patient and their family members as well?
Okay, I can have an analogy of cooking. If I can consider the staging, it is one, two, three, and four overall. It is a gross staging. So one is localized, two is somehow it is more than the localized or somewhat advanced. And stage three is locally advanced, and stage four is metastasis that already spread to the other organs. So if you can compare it with the analogy of a cooking, imagine you are cooking and notice the edges of the food starting to brown. So it is a slight burn. So it is a slight burn. So it is we can be fixed quickly by the scraping of the burnt or lowering the heat. So this is minimum intention, minimum intervention that is required to treat this problem like burning the burnt out. And the second stage is the significant portion of the dish has been starting to smell. We have to act fast. We have to do something more than intervention like the previous stage. So the damage is more extensive, but still manageable with extra effort of combination and techniques. And the treatment for stage two cancer is most likely with some sort of surgery with chemotherapy or radiation. So it is a mixed treatment. And next stage is the stage three. Stage three is advanced vaginal stage where the food is burning badly, smoke fills the kitchen. You need immediate intervention. You have to change the pot, like this sort of management. And whatever residue is okay, we have to be very much aggressive treatment, or aggressively we have to do something to die down the heat and all these things. So in that case, the multidisciplinary approach like chemotherapy followed by surgery or radiation, all this, all other immunotherapy, it is important. And whenever there is stage four, everything has been burnt out. The kitchen is full of smell. So then we need to important to remove the smoke to make the environment livable again. So cancer has spread to the other organs. So focus now shift from cure to improving the quality of life and managing the symptoms rather than cure. So stage 4 cancer emphasizes the palliative care. Some targeted therapies and immunotherapy may control the disease, but we cannot all time cure that patient in stage 4. So that is the important thing. That is, I can have an analogy of this cooking with some burning issues and the stages. So that I can explain to the patient and their caregivers.
All right. So finally, let's touch on palliative care. How can physician initiate
Mhm.
the early conversation and clear misconceptions about the importance of care?
So first of all, you have to identify the definitions of what is palliative care vis-a-vis what is end of life care. So these are not same. So palliative care is specialized medical care that focus to improve the quality of life. And the serious illness, maybe it is other, not only malignancy or cancer. Whether the goal is cured, whether it is a chronic management or comfort, whatever may be, but it is a part of the treatment. End of life care is a subset of palliative care where final stage of life it prioritizes the comfort and dignity of the patient. So end of life care is a part of palliative care. Most of the time, whenever we told patient that this is patient does not have any major curative treatment, we need to do palliative treatment. So they thought palliative is equal to end of care or hospice care. It is not like that. Palliative in most of the care, like chemotherapy followed by fatigue, post-operative pain, we have to improve the quality of life post-operatively or post-chemotherapy. So that's why palliative care is very important. So the importance of palliative care in curative settings like symptom relief, emotional support, enhance the outcomes of the curative patient also. And for conversation, we have to create the right environment to tell. It is not an haphazard. Patients came to us with the reports of stage 4 malignancy, and we abruptly tell, "Oh, this is stage 4 malignancy. We can't do anything. You need to palliative care." So this is not the right way, because it is a very bad news. You have to break the bad news in a comfort,
Gentle
like
way.
giving gentle way, so that the patient can handle this problem. Clarify the concept of is it using in the curative setting plus palliative care or only palliative care for non-curative options. So this clarification is very important. And there is some questions. There is some common questions like, does this mean there is no hope for a cure? So
Very
not
important
at
way.
all. Palliative. And so palliative care means if we can improve this quality of life, patients can handle the chemotherapy well. Patients can improve after surgery. That surgery may be also a palliative surgery. Maybe there is some obstruction and there is the problem regarding food intake. So whenever the patient comes with a gastrical obstruction, patient cannot eat. After eating, there is vomiting. So in maybe in the gastric setting, sometimes we have to select some cases. They can be undergone a surgery like bypass. We can bypass the gastric stomach. So these are also palliative treatment. So palliative treatment is integral part, not necessarily in the stage 4 disease, but also in the curative setting, because there are lots of studies and research that whenever there is a lung cancer patient, if we introduce the palliative care upfront in early stages of the treatment, the chances of patient getting better and they are more quickly get into the normal lives and gradually build confidence and then tell about this concept of palliative care, what actually we are going to do, how this palliative team care can manage all the problems, and what are the problems we are thinking about to relieve. So this environment, this communication is very important so that they can accept this fact and they can realize the difference between the end of care and the palliative care. So this is very important.
Absolutely. And that brings us the end of the today's podcast. A huge thank you to Dr. Sudip for joining us and shedding light on such an important topic. And thank you to our viewers for tuning in. And remember, if you're a healthcare professional who is eager to delve deeper into medical topics or have questions, do not hesitate to join us on MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. So until next time, stay healthy, take care.